and I think they urge us to continue to move forward. So, in that vein, we would like to start the memorial session. At the onset, I would like Dr. Sandeepti to sing an invocation to Lord Ganesha.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रान्विता या वीणा वरदण्डमण्डितकला या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवै सदा पूजिता सा मां पातु सरस्वती भगवती निश्चेषझाड्यापः।
Thank you, Dr. Deepti.
Thank you.
I request now Professor Rupam sir to come and pay homage to Madam and also light the lamps. I now request Professor Rupam sir to speak a few words about Madam.
Okay. Can you hear me? Can you hear me? So, for those of us who spent a better part of their life together, I don't think there's much to talk about Meena, other than the fact that we miss her very much. She was so vivacious and a personality that she would definitely light up the entire room whenever she used to smile, and would definitely touch people's hearts as far as it came to taking care of the patients, uh, taking care of the staff, taking care of the students. Anybody in the department who had a problem would immediately go to her. For her, it was she who used to give support and consideration and give practical advice whenever somebody had a problem. And there were many. I do remember the FESI workers going to her, the students going to her, the faculty members going to her. She was basically the mother hen of the department. And to lose a figure like that, once your comrade, once your colleague, it's not easy. Life has to go on. I'll just say a few words about Dr. Meena for those who don't know much about her. Okay. Just a few words. Basically, she happened to be born on the 1st of January in 1962. She was a few months younger than me, and she was actually born in Gandhi Medical College, where she spent her medical career, started her medical career, did her MBBS there, did her MD there. And in between, she was actually did her schooling at the Holy Family School, and being the punctual, meticulous girl that she was the head girl. And after that, I think that was one of the highlights of that she remembered very often whenever we used to talk of getting other people into line, into the correct lane, and do things properly. So she was very proper in the things that she did, the discipline of running the class, of doing the work. She was very disciplined, and she used to make other people equally disciplined. She was a clinician par excellence, also a thorough academician, and she would take history to a different level, and she used to take it out very well too. She joined NIMS as a resident, and she was the first lady resident of NIMS. Now we have a large number. At that time, she was unique. At that time, we had all male faculty. Now we have only sole male faculty. Uh, she actually did her residency here, then joined as a faculty in 1994 and served for 26 years. That's a long time. She was good in electrophysiology. She built up the critical care neurology. She designed the wards that we had. And we were very meticulous at that point of time. She chose even the curtains and everything else to make the place look good. It's actually, even now, in spite of having so many big wards, it's the best designed ICU because it has a window access, the circular ICU, and well managed. She did good work in multiple sclerosis, CIDP, which Dr. Satish Kadilkar will be talking. She also conducted the NerveCon in 2010, 2014, 2018, and she had a lovely occasions to attend, and I learned a lot from fellow colleagues, both from India and as well as from abroad. She was a good teacher and used to teach a lot, always teaching, whether it's in the OPD, whether it's in the ENMG lab, whether it's in the rounds. She was always teaching. She was really magnetic and full of energy. So we used to have a lot of things. She used to take the students out for movies, and like a mother hen, take the entire residents out for movies, which is not usually done in institute. But she was really caring for the patients, would fight to make sure that everything was down to the last and least amount of money that the patient would spend. That speaks a lot, a volume, the care she had for the patients, the students, and everybody else. I think that is a loss which is so irreplaceable. That's why we are trying to get over it slowly. Thank you.
I'd now request Kritika, Meena Madam, please, to say a few words.
Hello, can you hear me? Hello,
And you're audible, Meena.
am I audible now?
Yes, yes, you are. You are. Please go ahead. Yes.
Good evening, everyone. I'm Kritika, Dr. Meena's niece. Uh, I, I don't know. This has been a very difficult thing. I was not sure if I was going to talk today also. Uh, I thank Dr. Rupam, Dr. Rukmini, and the whole department of NIMS, Neurology, and also Dr. Satish, Professor Satish Kadekar for being here. I refer to Dr. Meena as Meenaka. She's my aunt, paternal aunt. So I'll be referring to her as Meenaka only right now. Uh, I don't know what to say exactly, but it's been a very difficult year for all of us. 2020 in general was a different year. I have to say, I don't know what to say exactly. Sorry. Uh, as I remember Meenaka, she was always the fun aunt for us. We were always with her. We expected her to be there every time. I think she would take us out. She would have this zeal for the youngsters actually. So she would be the fun aunt. She would take us everywhere, shopping or be anything. Even when we were sick, she would be the person who would actually not tell us not to have such ice creams or something. In fact, she would encourage us. You can eat everything, just because I am there, you don't worry about it. So she literally used to be the protector. I don't know what to exact. I don't know the word right now. She had a very difficult upbringing, and not difficult, but it was not the easiest and all. And probably that motivated her to excel in life in general and more academically. She was very, she was a bookworm. She loved her books. Even at, even now, even in at the even after she became a good professor and everything, she would study at 4 o'clock. She would wake up at early in the morning and she would be with her book always. She would motivate us, encourage us children in the house also to study all the time. In fact, our love for books was only because of her. She would buy different books for us. Like Dr. Rupam said, she loved going out with the residents, and she actually wanted. She was always wanted to motivate people. She wanted to push people so that they do better. Like the movies, she enjoyed movies. She would just go with movies, go to the movies with residents, and she would tell us. She would come home and tell this resident did that. She would have fun literally. Even with workers and all, we would ask her to be little not distant in a sense, but yeah, a little reserved because she would get too involved in things, and that would work her up. But she only saw the best in people. She only wanted the best in people in that way. Even in her last days, she was working for a thesis. I mean, she was awake in the early morning. Uh, when we asked her, why are you so awake so early in the morning? And she was like, this is for a thesis. A student had to submit a thesis and she was working on it. So she always wanted the best for her students. She was not the easiest professor, I think. She was a very strict teacher. Even I know it personally because where study wise, she wanted people to do best because she thought that would be what that is what would help them in future. So, she would feel bad if she had if she scolded a resident or something. But at the end of the day, it was only for our good that she was scolding us. I remember this conversation with my brothers. Like we like her as an aunt, but if she were our professor, we would be very scared of her. We didn't want her a professor because she was that strict as a teacher. she loved her patients too. She would always feel sad because her patients, she would say her patients all had these the diseases which cannot be cured. But she would always like them. She would hate it if someone went out of their way did something for her, because she just wanted a simple life, nothing else. I don't know what else to say. We all miss her. I know it's been a very difficult year, but this is she only wanted the best. Even NIMS was her life. She wanted the best for the institute. She totally wanted work towards the institute only. She would feel bad if anything happened in the institute, or if something is the standards were falling down. She would just complain. She would trip. She wanted to improve the quality of care we are giving in the institute. Uh, yeah, that's all I would like to say. And I don't know. I just thank you for being present over here at this time. Hope 2021 works better for all of us. That's all.
Thank you, Dr. Kritika. That that echoes all our sentiments actually. We really wish Madam was here still. We really wish that Madam was with us, and I think she's there with us all throughout and guiding us. But we will continue to miss her, and we will continue. I mean, to keep thinking about her at each and every point in our lives. I now request Dr. Javeen to introduce the speaker, Professor Satish V. Kadvikar.
Good afternoon, everyone. For today's memorial lecture, we have Professor Satish V. Kadekar, who is a specialist in neuromuscular diseases, which Dr. A.K. Meena Madam also was into the same specialty. He is MBBS MD DM from Mumbai, and he is specializing in neuromuscular disorders from Australia, New Zealand, and France. He is currently the professor and head of the Department of Bombay Hospital Institute of Medical Sciences, Mumbai. He is also the Dean of Bombay Institute of Medical Sciences. He is known for his extremely clinical as well as academic skills, and he has been editor for various textbooks of neurology as well as for various journals of neurology. He has also been member of various societies. Some of the famous awards which I would like to reiterate is that he is the best neurologist in Mumbai for neuromuscular diseases India Today 2012, and he's also received Gifted Teacher Award for 2019 from Association of Physicians of India. Sir, we know you for your work in calpanopathies, sarcoglycanopathies, and various muscle disorders. And today we'd also like to hear you from you first in other topic that is beyond CIDP. I welcome you, sir, for this lecture. Thank you, sir.
Thank you very much. And so shall I put on my slides?
Yes,
shall I share the screen now?
Yes, sir. Yes.
Right, the slides are coming. Hello. Can you see the slides, please? Hello. Hello. Can you see the slides?
Yes, sir, we can see the slides, sir, please.
Yeah. So shall I start? We are 10
Yes,
minutes ahead of schedule, but that's okay, I suppose.
Yes, sir.
Yeah. Okay. Right. So good afternoon, everybody. And I compliment Dr. Rupam Borgoim, Dr. Rukmini, and everyone at NIMS to start this memorial lecture. It's such a nice gesture for A.K. Meena. And also, I would like to thank them for asking me to be here to give the Professor A.K. Meena Memorial Lecture. Now, I knew her for a long time because, as some of you may not know, that my DNB examination was in IMS. Professor Mohandas was the examiner, and that's when I first met A.K. Meena, and then we kept meeting for this and that, and subsequently, because we were in the same subspecialty, I think so many different things were done as part of groups and together, and absolutely a fantastic clinician, a fantastic academician, as has been said, and ever smiling as you see this photograph that I organized every year. Every year she came and participated. Whenever I asked her, can she come? She never said no. She always found time to come. And this course was in 2015, and you can see Meena here, Dr. Pal here, Rakesh Singh, me, Dr. Sharma from AIMS, Muralidharan Nair, and of course, Dr. Matthew Alexander. She always participated in all these courses. And like was said a while ago, she worked on various topics on nerve and muscle and immunological diseases of the central nervous system. But she did focus on CIDP. So I thought that's the reason why I would choose this topic beyond CIDP. So let me introduce the topic to you. I mean, we all know the typical chronic inflammatory demyelinating neuropathy, or CIDP. But beyond the CIDP, classic CIDP, a lot of variants have been recognized, and the spectrum of the chronic dysimmune neuropathies has been steadily increasing. And it's important to know about them, and it is important to understand them from the point of view of diagnosis, from the point of view of appropriateness of the therapy that you want to design, and of course, for prognostication. So we really need to know what are the diseases around the typical CIDP that occur in people and sometimes are difficult to pick up. So let's just very briefly go through the typical CIDP. It's subacute to chronic, often fluctuating in course. It's usually sensory motor and more or less symmetrical. And the electrophysiology shows you conduction of velocities, slowing, conduction blocks, temporal dispersion. And there are various criteria of the European board, the American board, which for research purposes classifies or diagnoses CIDP. These patients respond to steroids, they respond to intravenous immunoglobulins, other immunomodulators, and sometimes they can be secondary to multiple myeloma, particularly the osteosclerotic, other neoplasm, and there is this issue of diabetes and CIDP. So that's broadly the typical CIDP. Now, what's atypical CIDP, or in a sense, beyond CIDP? There are these various forms which are pure motor and focal, the multifocal motor neuropathy, the sensory motor asymmetrical multifocal acquired demyelinating sensory motor neuropathy, or MADSAM. Then there is a distal sensory neuropathy, the DADS. Sometimes the CIDP comes acutely, the ACIDP. And then there are infrequent forms, which are restricted to the radicals, the chronic immune sensory polyradiculopathy. It's the pure motor and pure sensory forms of asymmetric proximal process, focal presentations of CIDP, and sometimes only a single nerve may be affected as the minimum abnormality in this spectrum. You could also classify these other things according to acute, subacute, and chronic, sensory motor autonomic, or involving the proximal, distal, and ganglionic segments. So these are the different ways of looking at the conditions around the CIDP. So what I've done for you is I'm going to go through case studies, because we are all clinicians and we sort of enjoy cases. So I'll show you some cases, and along that, we will see the characteristics of each of these conditions. So the first case, this is a slightly longish case. The 52-year-old chartered accountant who in 1990 had a right hand tremulousness and weakness. And then 2 years later, the problem was first only in one hand, and then 2 years later, tremulousness and weakness came in the left hand. At that point in time, the examination showed thickened nerves, asymmetrical weakness of the distal upper limbs, mild sensory decrease distally, and the tendon reflexes were present. This is the first time I saw him in 1993. And there is a very interesting, the way things are, I find it very interesting. I had joined Bombay Hospital in 1993, and Professor Singhal at that time was very, very busy, and it took a very long time for people to see him. And this man was basically seeing him. And then when he knew that a new neurologist has come in the hospital, he came to me and said, look, it takes a long time to see Professor Singhal. Can I see you? And then if necessary, can you talk to him? That's how I saw him first in 93. He was an unusual case, one hand at one time, then the other hand, the normal reflexes. And Dr. Singhal had asked him to see Professor Wadia. So he showed me Professor Wadia's notes in 1993. And I'm always amazed by how Professor Wadia, Professor Katrak, Professor Singhal kept their notes. Dr. Wadia typed notes, and Dr. Katrak beautifully handwritten notes. So he wrote there, on examination, I found his fundi and cranial nerves to be normal. There was a slight wasting and weakness of the muscles of the hands and fine rapid tremors of both outstretched hands. No fasciculations. He could walk on his heels and toes and rise from the ground well, but there was undoubted slight weakness of the lower limbs. There was no outstanding sensory loss. He mentioned that there was this slight blunting of pinprick. The tendon reflexes were preserved and the plantars were flexors. Dr. Wadia also felt that the right ulnar nerve was thickened and the left doubtfully so. The lateral popliteal nerves were tender and thick. So this is where I entered the case. And the case was already seen by two stalwarts in neurology from whom I learned about the case. Now, this man somehow started following up with me, maybe because I had more time for him. So I investigated it. His CSF protein was more than 1 gram. We repeated his electrophysiology. At that time, Dr. Mrs. Pandya was doing the electrophysiology, and she found multifocal conduction blocks at non-entrapment sites. And she told us that this is very likely an acquired neuropathy, which is demyelinating in nature. Now see the top picture. This man had a thickened greater auricular nerve. He had thickened ulnar nerves. But for some funny reason, his reflexes were present. Please don't ask me why. CIDP should have absent reflexes. Sensory neuropathies have absent reflexes, but his reflexes were present. And they were checked by everyone, and including Professor Richard Hughes when he had come for a neurology update. We showed him the case, and he also found them to be present. Right. So as the story goes on, from 92 to 96, he was on oral steroids, and some benefit he got. But the steroid side effects started coming, so they were tapered off. During this time, he noticed both hands wasting. 1996, he was unable to write. His nerves became more thick. His sensations were definitely reduced now. And the electrophysiology continued to show multifocal demyelination, and now with secondary axonal change. So 95, 96, the lower limb problem began. So the man started first with one hand, 2 years later, the other hand, then both the upper limbs wasting away, getting weaker, nerves getting thicker, and now coming in the lower limb. slipping of footwear without awareness. 99 and 2000, legs became weak. He sustained a leg fracture, went into bed. The problem increased after that, and he continued to have several falls. And he became more and more weak, required appliances. Then the proximal leg weakness came. 2008, he developed urinary difficulty. 2011, he was restarted on oral steroids. He again improved, and this time under my observation. So I can definitely say he improved. But the urinary symptoms didn't improve. So he was catheterized in April 2012. 2012, he had pain in the lower back intermittently, radiating to both legs, and I tried a CSF examination. You will remember the protein was very high initially. This time it was a dry tap. I asked an anesthetist to come. It was still a dry tap. So what do we have here? We have a man in his 40s who starts with one hand problem, then the problem goes to the other hand, then the problem slowly progresses. He gets some benefit with steroids, then it comes to the lower limbs, and it gradually goes on worsening, and then a urinary problem comes. So at this point in time, Bombay Hospital had got the MRI software for neurography, and we were getting very interested in the neurography. So we already had electrophysiology showing multifocal conduction blocks. We had this asymmetrical presentation, and we had the urinary problems. So he is one of our first few MR neurography patients. And you can see how large the sciatic nerves are. Huge, literally like elephant's trunk. See them? Also, you never see these intercostal nerves like this. So all the nerves were extremely thick. And here you can see how it is on the transverse section. So he had a hypertrophy of the nerve. So our diagnosis at this point in time was that this is the Mad Sam variety. Now, why the urinary symptoms? He is a male person. Is there a prostate going on? What else is going on? So we asked him to go to the urologist. Nothing was found. And because the urinary symptoms were there, we did an MRI of the cervical spine and MRI of the whole spine. And you see what's happened here. This cord here looks okay. The cord above looks okay. That's the normal cervical dilatation. And as it comes down, you can see that where the nerve roots are, the cauda equina, there is no space left. The hypertrophic nerves have smothered themselves in the cauda equina. So this is the most unusual enlarged hypertrophic Mad Sam, where the nerves are so thick that they smothered themselves, producing a cauda equina syndrome. I was absolutely intrigued by what was happening and tried to look up the literature. So we found some references, even though it is very, very unusual, we found some references. The hypertrophic nerves producing a myelopathy in a fulminant case of CIDP. So here you see how large the nerve's roots are as they come out. So there was another patient later on. This is a different patient in whom we again saw a lumbar canal stenosis-like presentation. Lumbar canal stenosis-like presentation, which actually was a CIDP, and you can see here that the roots were very, very large. So what are we seeing here? This is I think, a very good example of the Lewis-Sumner syndrome or the Mad Sam, which is a striking multifocal presentation. It's a very slowly progressive demyelinating neuropathy. Upper limbs are affected more than the lower limbs. Distal and then becomes proximal. Only our patient was male, whereas this disease is a little more common in females. CSF protein is very elevated. I mean, this here it was more than a gram. Usually it doesn't go that big in MMN or other conditions. and the GM1, IgM antibodies against GM1 sometimes are positive. Its asymmetry is the hallmark. And the other asymmetric condition is MMN. So the sensory findings separate the MMN. The snaps are usually low, and you see a D-end remyelination on the biopsy. So this is from another patient, a patient of mine with a classic CIDP, where you can see the folds and the D-end remyelination producing the onion bulb appearance. And under high power, you can see the folds and the stretched out nuclei and everything. So that is MAD-SAM. How do you treat them? They respond to steroids. They also respond to IVIG. And when they are resistant, people use other immunosuppressants, including rituximab, in those patients who are resistant. So we have seen the MAD-SAM, which I think is perhaps the most common atypical form of CIDP. Now let's go to case 2. Case 2 is a 26-year-old male. In October 27, he was a chartered accountancy student. And in October 2017, he developed difficulty in the right side hand grip. He was unable to write. His thumb had become weak. His forefinger had become weak. And there was tremulousness of the right hand while holding objects. He was started on physiotherapy by his practitioner. It didn't help. A few months later, the right index and the middle finger started dropping. Then mild weakness came on the third and the fourth fingers. He saw a doctor. The doctor found pure motor distal weakness at young age, and he wondered about an anterior horn cell problem similar to what happens in Hirayama disease. And he was actually sent to me with a provisional diagnosis. Is this Hirayama's disease, but not seen on the MRI scan. So this is how he was, the wrist and a wrist drop. And I'll show you some pictures again afterwards. So we got this person with one-sided distal pure low motor neuron problem. His hemoglobin was 14, MCB was 87.9, sedimentation rate okay, calcium, thyroid, parathyroid, creatinine, uric acid, liver function, everything okay. So we did an electrophysiology at Bombay Hospital, and they found a right radial neuropathy, but they reported that it was mainly the posterior intraosseous neuropathy. And they also found evidence of a partial conduction block. So there was a right radial mononeuropathy affecting mainly the pin with a partial conduction block. Now, MR neurography was of yours for a while. So we did his MR neurography, and it picked up an abnormal signal and thickening within the right radial nerve. But it was much wider than what we had believed, starting from the spinal groove, radial groove, to the bifurcation, but largely the signal was in the PIN, and there was no obstruction that they could find. So we had a patient with a finger drop, wrist drop, young age, progressive course, electrophysiology and MR neurography coming together to the posterior intraosseous nerve. So what were we dealing with? He was largely motor. So I was seeing him jointly with one other doctor, and we're talking to everybody. We put him on corticosteroids, a little reluctantly because he was motor. And he first took injection methylprednisolone in another hospital. It was followed by tablet prednisolone in tapering doses. But believe me, steroids did nothing to him. He was as before. In fact, he was a little worse. Then we put him on IVIG, thinking that this is a multifocal motor neuropathy. We did the antibodies, which turned out to be negative. And the IVIG helped him a lot. And then we have kept him on maintenance. This is one patient who is now following up with me for 3 years. from end of 17 till now. And he improves with the IVIG. He comes to know when the IVIG is again due. And then he sort of asks for it. He takes the dose, which is usually at about 8 weeks interval. And we give him one booster dose, 1 day IVIG course, 400 mg per kg. And he maintains very well. So this is how he was in the beginning. And now the wrist drop has improved. I showed you originally the drop wrist. And you see here, the fingers opening much more. So he's improved. He's not normal, but he's improved a lot. Now, another beautiful thing is he, with his physiotherapist, have kept beautiful notes as to how every muscle goes. And you can see here that extensor carpi radialis and ulnaris have improved here. These are the times when he's received the IVIG, and this is how he's gone on improving. This is MRC grade 0 and MRC grade 5. So you see how he's picked up after the IVIG. Similarly, his finger muscles, how they have improved. And lastly, the thumb muscles and the intrinsic muscles of the hand, they have also improved. But various muscles in this person have improved to different levels. So when you say IVIG helps MMN, it doesn't improve every muscle with the same intensity. It's variable. Some things are improved more than the other. So this is an example of motor neuropathy with conduction block. It's quite an uncommon condition, and the important lies in the fact that it really looks like motor neuron disease. It's uncommon. It's a little more common in males at younger ages. Our patient was in the 20s and was a male patient. It either slowly progresses or does a step ladder pattern. It is again almost always asymmetric. It starts in the upper limbs. MAD-SAM can come anywhere, but this starts in the upper limbs. And it may relate to an individual peripheral nerve, like in this patient, it was the PIN branch of the radial nerve. So it's very, very focal. So atrophy, fasciculations, and muscle cramps come in 50%. Sensations are usually normal. And in some patients, the tendon reflexes can be brisk. So see how important it is to differentiate this condition from amyotrophic lateral sclerosis or motor neuron disease in younger individuals. They evolve slowly, uncommonly they suddenly deteriorate, and rarely spontaneous remissions are known. Now, conduction blocks occur in motor nerves. They could be very proximal. So you've got to go on searching proximally. And blocks are not mandatory for the diagnosis. Blocks improve with IVIG, but axonal degeneration can occur. IgM, serum antibodies are seen in 30 to 80%. Again, antibodies are not a must. So in a given case, if antibodies are not there and blocks are also not there, then you really have very few clinical anchors to go by. Now, unlike the MAD-SAM, which improves with steroids, MMN either does not improve with corticosteroids or sometimes worsens with corticosteroids. MRI shows changes which may be more widespread, like we found in our patients. Sometimes a lot of thickening is also found. And onion bulbs have also been reported in the areas where you suspect the conduction block. And more studies have shown axonal degeneration. However, whenever people have done a biopsy from the MMN patients, inflammatory cells have been rarely seen. Whereas in CIDP and in MAD-SAM, you see them a lot of times. So different disease mechanisms must be operating. So don't use glucocorticoids. Even plasma exchange is ineffective. That's a very curious thing. Steroids don't work, plasma exchange doesn't work, but IVIG works. As the conduction blocks improve, patients improve, but antibody levels don't change. So there's a lot happening here which is unexplained. So I think about the MMN, younger patients, upper limb, usually a wrist drop, male patient, step ladder pattern, conduction blocks which may be very proximal, MRI changes which may be more widespread, normal sensory, except for research settings where they go into big depth, some sensory changes can be seen. Antibodies in some patients, blocks in some patients, and response to IVIG. So we have now seen the second type, the multifocal motor neuropathy. Now we go to the third case. Third case is a 64-year-old man who had weakness and wasting of the left upper limb of 2.5 years duration, inability to walk on toes, which evolved over 6 months. So again, upper limbs followed by lower limbs. An examination showed an asymmetric sensory motor neuropathy with distal involvement, which on electrophysiology was multifocal. And his serum protein electrophoresis showed a minor M band consistent with the diagnosis of MGUS. No skeletal lesions, no organomegaly. So this is another example of a demyelinating neuropathy. Now in this patient, it was asymmetric, but largely you see a symmetrical lower limb neuropathy with the MGUS. So it occurs in older people. It is chronic. It's usually distal, symmetrical, sensory motor, and mild, but it can lead to gait ataxia in some patients. Is the presence of monoclonal protein, and you have to track them because these cases can then turn into myeloma and other disorders. So you don't ask for a routine serum electrophoresis, you ask for immunoelectrophoresis or immunofixation to detect the small amounts of protein, like was done in this patient. Now, we don't know how to treat them for sure. In some patients, the immunomodulatory treatments have resulted in serious side effects. So, a patient of CIDP with the IgG gammopathy is to be treated like a CIDP without gammopathy, unless the gammopathy is part of a well-known syndrome, like a multiple myeloma, where the treatment will go as per the multiple myeloma. Some of them don't respond too well, and even rituximab and cladirabine may be required. Of course, there's a differential diagnosis for this condition, as this slide shows you. I do not have a case of DADS. I have a suspected case, but I didn't get all the details for this. It's exclusively distal, and it is sensory, as the name suggests. Distal acquired demyelinating sensory neuropathy. It's like burning feet or loss of sensations in the feet. Sometimes there's no proximal weakness. So these patients come with gait unsteadiness and tremors. And very interestingly, the motor nerve conduction study showed demyelination and markedly prolonged distal motor latencies, even though the problem clinically is sensory. Then IgM kappa monoclonal protein is found abnormal in 50% of the patient. It's a bad disease to diagnose. It's a bad disease to get because these people are very resistant to therapy. In this suspected case that I've tried everything, prednisolone, IVIG, plasma exchange, but it hasn't worked. So even though it's just a distal process, it's a neuropathy that is very difficult to treat. So we first saw MADSAM, then we saw MMN, then we have seen MGUS, and then we have seen DAGS. Now let me take you to another very interesting area. And this patient, this was the first patient of this disease that I saw about 15 years ago. He was a 46-year-old man from Bengal and had a 5-year history of tingling and numbness in both feet and slipping of footwear without knowledge. And last 1 year, he developed difficulty in getting up from sitting position. He had an imbalance which worsened on eye closure, and he'd also noticed some twitching movements in the calf. So primarily sensory symptoms of the lower limbs of a very long duration. He had hypothyroidism with hypertension, which was adequately controlled. An examination showed a profound deficit in the joint position. Vibration was lost up to anterior superior iliac spine. Comparatively, he had very mild weakness of dorsiflexion and iliopsoas. Tendon reflexes were absent in all four limbs, and his Romberg's test was positive. So, where is the localization? This is a large fiber sensory loss. Is it peripheral nerve? Is it proximal root? Is it dorsal root ganglion? Is it spinal cord? Again, there's a little anecdote here. This case was admitted in the late afternoon. And after I finished my outpatient clinic, I told the chief third-year resident that let's see him. I don't know what he's got. So very interestingly, he said, "Sir, come tomorrow morning. Give me give me some time to look him up." So by the time next morning I went for the round, he had clinically examined him, done an electrophysiological test, done an MRI, and he was all ready. But he was all puzzled. And I'll show you what happened. His electrophysiology was normal. He thought I'm looking at a sensory ataxia and I'll find something. But his distal nerve conduction on the sensory and motor side were completely normal. Therefore, the electrophysiologist did a SSEP, which was abnormal. And from the upper limb, it was normal. He did a B12 because it was a sensory ataxia, which was normal. He did a spine MRI, which was normal. So to cut a long story short, we went to our MR neurography. And again, when this patient was being done, it was our early time for MR neurography. But it clearly showed huge thickening of the nerves. See here. Huge thickening of the rootlets. And you see here the S1 roots are particularly thickened. These are the dorsal root ganglia, by the way. So it's a preganglionic segment, dorsal root ganglion, postganglionic segment. And in fact, originally when we started MRN, we were very thrilled by this. So all these views were taken, and you can see that the S1 roots are much enlarged. The CSF protein was elevated, and there were non-specific oligochronal bands present. Sedimentation normal, protein electrophoresis normal, vasculitis workup normal, not HIV, not HBS. Normal distal conductions, normal SSCP from the low limbs getting delayed. So there's a selectively proximal demyelinating radiculopathy affecting lower limbs causing sensory ataxia. Now this patient therapy and the modified Rankin score improved by 2 points within 6 months. He is from Kolkata, and whenever IN was in Kolkata, I had a chance to see him, and he's remained well almost 10 or 12 years after the diagnosis as well. After 5 or 6 years, his immunosuppressants were totally stopped. So what is this condition? There is only selective involvement of the sensory roots. So this comes under the currently getting clarified category, chronic immune radiculopathies. So what are they? These are isolated involvements of the roots. The nerves remain normal. Therefore, the distal conductions like sensory and motor are normal. But F wave, H reflex, and SSEP turn out to be abnormal. And MRI shows thickening of the roots, usually the postganglionic segment. And there is an albuminocytological dissociation to say that the process is rather close to the spinal cord. So, infrequent is a simpy, but more common is a mixed form. So I'll give you a little background of this because I'm greatly interested in this selective involvement of the roots. The first paper is by Sinnerich along with James Peter Dyke. Chronic immune sensory polyradiculopathy, which they call CISP. And what did they find? They had 15 patients with sensory ataxia and areflexia without weakness. See, that part without weakness tells you that there is a dissociation between sensory and motor, and that usually doesn't occur at the level of the peripheral nerve. So that's one clinical indicator that it may be a little more proximal. So as expected, they have normal distal conduction studies, prolonged SSCPs, and albuminocytological dissociation. These, out of the 15, they did MRIs of in 5 patients, and they found thickening of the rootlets. And they had 3 biopsies of the rootlets which showed inflammatory changes. And their patients respond to steroid. After the initial description by Sinnerich, there are papers to show that there are cranial neuropathies in such patients. There are usually case reports. And somebody said that SSEP can be used for monitoring. People have used corticosteroids, and most people feel that corticosteroids help. IVIG has also been used, and sometimes more aggressive immunotherapy has been used. Except there is a very important case report by Rajabali and Wong, where they had a patient who unusually went downhill with steroids and then later improved with IVIG. So that's a bit of a word of caution. So Sinnerich actually brought this CISP as a term in literature. Now, O'Farrell, from his group only, because Michael Sinnerich is the last author in this paper, probably from the same group, gave description of one patient who had a choroid hypertrophy with onion bulbs, and he thought that this is a counterpart of CISP, and they called it CIMP. But really speaking, this is the single case report in literature that I could find. So it's not something that people have seen around the world. Now, on this background, I think in 2015 or so, we had a patient and then a second patient in whom all that you said about the Sinnerich paper was present, but these people were weak. So they had a motor weakness, they had a sensory weakness, and they had electrophysiology showing both the motor and sensory proximal conductions to be abnormal. So we proposed at that time that based on these 2 patients, it may be that there is a third form that exists, and it is CISMP, chronic inflammatory sensory motor polyradiculopathy. So these 2 patients got into the literature. They improved with steroids. They didn't behave any differently than the CISP patients. So sensory ataxia, areflexia, weakness, albuminocytological dissociation, and good response to immunotherapy. Now, very interestingly, the next year, there were 9 patients of CISMP detected from 2 centers in United States by Bashir Katirji's group. So, I mean, these were somewhere, but they've not been put together as cases of CISMP. Maybe somebody looked at this and then wanted to go back and found 9 patients. So a series came into existence, and I was very happy that what we thought other people are also seeing. So they had 9 patients, but this was a retrospective evaluation for 2 big centers from United States, one being the Harvard. And weakness, sensory ataxia, areflexia, albuminocytological dissociation, thickened roots, and response to immunotherapy. So same pattern, but motor and sensory. Now, in the meantime, in the last 12 weeks, we had 8 patients of all these 3 forms. 2 patients with the CISP, 2 patients with CIMP, and 4 patients with CISMP. So we analyzed them. And by now we knew what to look for. We knew that there is a motor form, we knew that there is a sensory form, we knew that there is a sensory motor form. So we were doing very good electrophysiology, proximal motor, proximal sensory. We were doing very good MR neurography because we had a new software, a new machine. So we tracked all these 8 patients. And what we actually found was that these are 3 clinical variants of what seems to be a same process. And why do we say that? because if you look here, their MRIs can't be separated. This is the CI SMP MRI. This is the this is CISP MRI. This is CISMP MRI. This is CIMP MRI. They all look the same. Their response to treatment is the same. So we sort of this year only, I think January this year, Muscle and Nerve has published this manuscript saying that all the three, CISP, CISMP, and CIMP, are forms, three clinical variants of the same disease. Now, we sort of term them this way: CISMP to say that it's sensory dominant, CISMP to say that it is motor dominant, and sensory motor when both are dominant. So the chronic immune polyradiculopathies are clinical puzzles. You can't easily diagnose them. And you need SSEP and MRI neurography. It's very important because they are treatable. They're also very slow. They go slowly. Now, in the same issue where Muscle and Nerve has published this manuscript, on this manuscript, there is an editorial by Rajabali. And he makes a very nice point. You know, in medicine, there are lumpers and splitters. So splitters go on finding differences, lumpers go on finding similarities. So here we found similarities in these three forms. He goes on to rate the isolated radiculopathies from the CIDP, lump them in CIDP. He's taken the lumping one step further. And what's his argument? His argument is that if you call them CIDP variants or CIDP forms, all the therapeutic trials that have happened in CIDP are applicable to them, and you are justified in using steroids and other things. Because in the world literature, there is Sinaraj series of 15, then Katirji's series of 9, my series of 8, and then isolated case reports of maybe 10 or 12 people. So how are you going to justify treatment? So he makes a beautiful point there, that lump further and call them parts of the CID. Yeah. So we have seen MATSAM, we have seen MMN, we have seen DADS, we have seen MGUS, now we have seen CISP, CIMP, CISMP. There are a whole lot of forms. You know, these photographs are by my son, and this photo actually makes me realize how small we are in this whole universe. This is him, and it's a drone shot with some tricks. I think we consider what we do too much with a lot of fervor. We really are like a speck or a pop-up in the whole game. So I'll take you to the next case. And this is courtesy Professor Nadir Barucha, who is my senior colleague at the Bombay Hospital. He is a 42-year-old male, progressive numbness of the right hand since 2 years, numbness in the left hand since 6 months, weakness of the right upper limb since 3 months. Significant wasting of the intrinsic muscles of the right hand, weakness of the shoulder and arm as well, pinprick temperature reduced in the right hand, deep tendon reflexes absent in both hands, and no thickened nerves. So clinical impression, flail arm, right more than left, flail arms, right more than left, and localization probably brachial plexus. But bilateral plexopathy is quite uncommon. CSF protein elevated marginally, no cells. And again, electrophysiology shows a multifocal, motor more than sensory, demyelinating, asymmetrical, with minimal demyelination in the lower limbs. So like we saw the MATSAM, this is lesser than that. This is on the just one plexus or both plexi. So we've now really grown fond of the MR neurography. So see the MR neurography. These red arrows means one particular radiologist has reported it, Sonali Shah at the Bombay Hospital. So you see how they're taking up contrast. And they're not taking up that sort of contrast on the other side, even though we think they're slightly thicker than normal. And I'll show you case 6 along with this. This again was at a time when I was much newer in neurology. This man is also 42-year-old, and he had a 25-year history of the flail arm, progressive weakness and wasting of the left upper limb, 25 years. His first clinical examination was in 1979 by Professor Wadia again, and he had nothing sensory, pure motor. It was thought to be some awkward form of monomelic amyotrophy. It was proximal as well as distal. And when we did the modern electrophysiology, there were very proximal conduction blocks in median and ulnar nerves. And there was evidence of demyelination, particularly in the left brachial plexus and going a little distally in the nerves, with conduction blocks and dispersion. So this was a very, very slow, very, very focal, very largely motor, little bit of sensory plexopathy. And we actually saw tomocula. This photo is not too well because I've taken it from the plate. This patient is lost to follow, which actually said we actually suggested him a biopsy of this tomocula-like thing, but he refused. So these two patients are examples of hypertrophic plexopathy. Like MADSAM is asymmetrical, MMN is asymmetrical, but over a period of time they become generalized. These two patients have largely remained, second more than the first, largely remained restricted for years together. And the second one is really 25 years. Who would have thought that a demyelinating process will be like this? So these two cases show you that they can be chronic, they can be very focal. And here nerve conduction studies and MRI neurography is again very important. So we'll go to the second last case. This is an acute CIDP. And this here, I think Dr. Varsha Patil is my younger colleague who actually looked after this patient, and I was jointly on the case. This is a 6-year-old boy who came with an acute areflexic quadriparesis like GBS with demyelinating electrophysiology and some rise of CSF protein. He recovered with IVIG. Everyone thought the story is closed. But then after a few weeks, he again started deteriorating. And for many weeks, he went on deteriorating. And he had continued to have a demyelinating multifocal neuropathy. And the MR neurography shows you thickening of the nerves as he's gone on many weeks into the illness. This is a very recent case. This is in November, 6/11. And Varsha has made this. This is how bad he was. And IVIG didn't help him too much. Methylprednisolone didn't help him too much. But when Varsha put him on plasmapheresis, he improved. And now we have actually given him rituximab. So he can now lie down, he can now sit up. So he's not normal, but he's so much better. Right. So as you have seen in these cases, so ACIDP is a very important form because every time what looks like a GBS may actually not be GBS and may turn out into CIDP because finally it's a spectrum. And as we have got more and more expertise on MR neurography in our radiology department, you can see some fantastic pictures. This is a CIDP, this is an hereditary neuropathy, HMSN, and this is a patient with neurofibromatosis. And there's a paper now in European Journal of Neurology 2019, where they had patients who clinically looked like CIDP, who didn't fulfill the electrophysiological criteria. They did the MR neurography. And their conclusion is that our observation suggests that the plexus MRI makes a valuable contribution to the diagnosis of CIDP ND, ND meaning where the electrophysiology is not diagnostic. And further studies are needed to investigate the inter-rater reliability, which is a big issue in this because there is no normative data available as yet. And we're actually trying to create that. Right. So Dr. Narayan Deshmukh, who just finished his work with me and now he's studying further. we looked at all our cases with enlargement of the roots, plexus, and nerves, and we had 133 patients. And we tried to see which investigation helps where, optimizing investigation. And what we actually found was leprosy without thickened nerves. Even though the approach has to be holistic and all the different things have to be taken into account, the MRI seems to be the main thing, helps in leprosy without thickened nerves. The CISMP you really can't diagnose without these non-compressive mononeuropathies, and I'll take you to that. Try and differentiate inherited from acquired neuropathies and cranial nerve tumors. So we feel that amongst all the different tests that you can do for diseases that enlarge the nerves, MR neurography is playing a central role. So I think it pays to develop the expertise and software for the MR neurography. Now, while we were studying these different things, we came across mononeuropathies. And I'm showing you 3 examples. One of a radial nerve, one of the musculocutaneous nerve, and one of the sciatic nerve, where there is a subacute to chronic mononeuropathy, biopsy showing inflammatory cells, response to steroids. And we actually don't know what they are, but we think they are the minimum unit forms of the same process that gives a brachial plexopathy, that gives MAD-SAM, that gives this. But we don't know. In the world literature, there are very few patients recorded like this. And here is one such patient who had the last MRI that you saw, this MRI, with the sciatic neuropathy and the denervation changes that you see. So this is how he was before treatment. And after steroid treatment, he's improved quite a bit. So these are again, I think, the minimum forms of the same spectrum. So we have seen MAD-SAM, we have seen MMN, we have seen MGUS, we have seen DADS, we have seen CISMP, CISP, CISMP, brachial plexopathy, mononeuropathies, and ACIDP. These we would consider the forms outside the typical CIDP that you may see from time to time. So what are the differences between typical and atypical CIDP? What are the leads? Asymmetrical presentation, pure sensory or pure motor presentation, slower progress, months to years. Nerve conduction study is normal. SSCP is required for the diagnosis. Similarly, F wave, H reflex required for the diagnosis. MRI study a must with a neurography for all these suspected cases. That's how you differentiate, use the tools to differentiate between typical and atypical CIDPs. Why is it important to know about all this? Because these are under-recognized, they have variable clinical features, but they are treatable. So we have to pick them up and not miss them. And the key investigation are detailed electrophysiology, including SSEP, F wave, H reflex. MR neurography is, I think, invaluable. CSF studies, antibody levels depending on the case, biopsy when you're in doubt. Let me make a point about the biopsy. When feasible, do a biopsy. From time to time, we have seen a lymphoma, we have seen a leukemia, we have seen a sarcoidosis, we have seen perineuromas and nerve tumors. So very important. And lastly, genetic studies, because what looks like acquired may be inherited and what looks like inherited may be acquired. So nowadays they are very easily available. So we should take help with them. Obviously, since these are very different forms, some motor, some sensory, some distal, some proximal, like CISP, CISMP are proximal, DADS is very distal. Some are motor, like MMN, some are sensory motor, like MAD-SAM. So there are obviously more mechanisms going on than what we understand. But it's important to put them together, because only when we will try and put these together, a clearer picture of what the whole thing is about will emerge. So these are my colleagues who helped me in collecting this material. clinicians, radiologists, pathologists, electrophysiologists. So it's teamwork and it's group work. And I must thank all of them. Even though they allow me to represent everything that they do, I think they are the ones who actually do it. And also let me pay my respects to all my teachers and senior colleagues, Professor Noshir Wadia, Dr. B.S. Singhal, Professor S.M. Katrak, with whom I had a very long association and I continue to learn from him. Professor Anil Desai of myopathies, Darab Dastu, the neuropathologist, and Professor Nadir Barucha, who is my senior colleague, consultant, and always encouraging me to do more and more at the Bombay Hospital. And two mentors outside India, Byron Kakulas, who made me do neuropathology, and Professor Martin Pollock, with whom I did training of the nerves and understood that unless you do the nerve teasing well, the nerve will tease you. So I think just to close, we know only a little bit. We think we know a lot about our science, but the truth is that the unknown is more than known. Only a little bit is known. A lot is not known. So I think we have to be aware of that and appreciate the fact that there is a lot that is not known. And I cannot help putting this slide up. I mean, it was so disturbing to see such a exuberant, charming, and vivacious person suddenly sort of not being there. I think let's all remind ourselves life is short, time is fast, there is no replay, there is no rewind. So let's enjoy every moment as it comes. And as medical doctors, let's try and put all our moments to the benefit of others. And would again like to thank Rupam, Rukmini, and everybody at NIMS for asking me to be here. And thank you all for being here today. My respects to Dr. Katrak and Dr. Barucha, who I think are listening to this. Thank you very much.
Thank you, sir, for a very beautiful, enlightening lecture. This is, it reminds us of so many days with Meena Madam, actually. I mean, the same clinical enthusiasm, the excitement of having to look at a patient with, I mean, which would be a mystery and that would be like unraveled slowly and
Yes.
carefully.
Sometimes it takes years. Sometimes it takes years to really know what the patient was having. He has to keep coming back to you. That's another another important thing. Yeah.
Thank you, sir. So, I will end the session, and I'd like to thank all the esteemed guests who have come here to listen to the lecture. Professor Kadilkar sir, who has graciously accepted it as it's one Jain is paying homage as a part of the first memorial lecture for another Jain. So, the Department of Neurology and the entire NIMS who has backed in starting up this lecture. I know this is COVID time, and we wish it had been more. Hopefully it'll be live from next time, and we'll all be able to meet each other. But I would like to thank the Crescent Pharmaceutical Company who actually helped us set up this whole Zoom meeting without having much of a problem, and the entire uh, urology residents and other staff who has actually helped us with this program. I thank you all once again for coming here in spite of having a busy schedule in the evening and reliving the memories of Professor Meena. Thank you, sir.
Thank you. Right. So, yeah. First, yeah. Before I leave, can I? Which pharma is supporting?
So
Hello?
actually, the Zoom. Webinar has been.
No, my basic interest was to get a recording.
Sure, sir. We
Is
will
that
send.
possibility?
Yes, sir.
Yeah.
We will send you the.
Sir, I'll just send you the link, sir. It is recorded
Yeah.
on YouTube. I'll just forward you the link, sir.
Yeah. So you're going to put it on the YouTube.
Yes, sir. It's already there. I'm streaming it on to another channel.
It's already.
I'll send you the link, sir.
Great. Please do.
Yeah,
Right. Thank you very much. I think you were terrific. I think there was not a single glitch technically.
Yeah. Thank you so much,
Fantastic.
sir. And the
Yeah.
problem was I think you were on Wi-Fi, sir, if I'm not wrong.
Yes.
That gave me some problem, sir, because the bandwidth
Okay.
was going low and up. So next time, be careful, sir. Always do it
Okay.
on wired connection only.
Okay. Will
Thank
do.
you so much, sir.
Right.
We'll,
Dr. Rukmini, thank you very much for everything. I think you orchestrated it beautifully.
so thank you,
Thank
sir,
you.
again, once again, for agreeing to come, sir, and we will.
No, it's my
and thank you.
pleasure. Is Rupam there? Can I
Yes, sir.
just say bye to him? Hi, Rupam. Hi, Rupam.
Hi. So that was very
Great
gracious. Thank you very
great
much.
organization. Enjoyed it.
Entirely
And I
out of
think,
stuff.
yeah, I think it's a great thing you have done. I think Meena deserved this for sure. Yeah.
Definitely miss her a lot, and this is the very
Yeah.
least we can do. Thank
Yeah.
you. Thanks a lot.
Thank you. And how are you keeping? Well,
Yeah, we're getting along.
yeah,
Not
knees
funny.
troubling. Yeah. Yeah.
No, that's
Right.
okay.